to thank the Diabetes Team India for inviting me to be part of this wonderful scientific congress and their wonderful extended hospitality. So, coming to the PCOS, PCOS is actually such a vast topic that it's actually difficult to cover in the time allotted, but I would like to stick to the time. It was first described in 1935 by F. Steen and Leventhal as a syndrome complex associated with anovulation, and that is why it was known as Steen-Leventhal syndrome to begin with. And they described the association of enlarged scleroscystic ovaries with the amenorrhea, obesity, infertility, and hirsutism, which still remain the main symptoms of the PCOS. Although the definition of the PCOS has progressed to various signs and symptoms, but the recent one which we are following is the one which was given by the Rotterdam Consensus meeting in PCOS in 2003. It defines PCOS as the presence of any of the two of three criteria out of these three. One is the ultrasound appearance of polycystic ovaries. Second is the menstrual disturbance, and the third is evidence of hyperandrogenism, which could be clinical and biochemical features after you have excluded all the other causes of hyperandrogenism, especially congenital adrenal hyperplasia. The clinical signs of androgen excess are hirsutism and acne, and which manifest in the form of biochemical signs as increased levels of androstenedione, free testosterone, DHEAs, free androgen index, and increased LH levels, which are the main culprit for all the signs and symptoms of the PCOS. If you look at the ultrasound diagnostic criteria of PCOS, the Rotterdam has defined that ovary would be known as a polycystic ovarian syndrome if either in one or both the ovaries the ovarian mean volume is more than 10 cc. If the ovary has more than 12 follicles ranging from 2 to 9 millimeters in diameter, and there is a eco-dense stroma, and you can see the ultrasound picture, which is like I don't know, the slide is not coming. The ultrasound picture, which is typical of this necklace appearance of the follicles around the ovary with a dense stroma in the center. So this is classical picture of the ultrasound. The other etiologies which should be excluded from the diagnosis of PCOS are congenital adrenal hyperplasia, androgen secreting tumors, the Cushing syndrome, thyroid dysfunction, hyperprolactinemia, and drug-induced androgen excess. And it is worthwhile to remember that PCOS is most of the times associated with thyroid dysfunction and hyperprolactinemia both. If we look at the incidence of PCOS, it's unknown, but it is the most commonest cause of anovulatory infertility among the infertile women. And it is seen that 90% of the infertile women with anovulation have PCOS. The prevalence of PCOS is about 40% in women with impaired glucose tolerance and 85% in those with type 2 diabetes mellitus who have associated menstrual irregularities. Coming to the pathophysiology of PCOS, there are three main culprits. One is the hyperandrogenism, which is present in almost 70% of the patients of PCOS. Second is anovulation, and the chronic anovulation leads to increased LH levels, the buildup of endometrial stroma, which can be a precursor for the endometrial carcinoma in a later stage of a woman's life. Third is the insulin resistance, and it has been seen that 50% of the patients with PCOS will have insulin resistance and hyperinsulinemia. So this is the origin and sequelae of the abnormal neuroendocrine function which happens in PCOS. In PCOS women, basically from the hypothalamus you have increased LH pulse frequency than the normal one, which leads to the increased LH levels, and that leads to increased LH-FSH ratio. Normally it is 1:1, but in PCOS you might find that it goes as high as 2:1 or 3:1. This increased LH ratio leads to increased ovarian androgens, and there is impaired hypothalamic progesterone sensitivity. And similarly, because of the increased LH levels, the FSH levels are comparatively lower, which leads to impaired follicular development, and so they have impaired progesterone production, which leads to recurrent miscarriages and difficulty in getting pregnant. Now coming to the pathophysiology of hyperinsulinemia and hyperandrogenemia. Hyperinsulinemia is basically there is an insulin receptor dysfunction at the level of pancreas, which leads to hyperinsulinemia. It acts on the liver, so you have reduced sex hormone binding globulins, and which leads to increased free androgens. From the hypothalamus, we have already seen there is increased LH pulse frequency, which acts on the stroma and follicle, which leads to elevated androgens, and the hyperinsulinemia also acts on the adrenals, which gives you elevated DHEAS levels. DHEA, DHEAS and androstenedione, these are the weak androgens which are metabolized in skin to dehydrotestosterone. And testosterone is basically the principal circulating androgen, which is also metabolized to dehydrotestosterone, and these go to the dermal papilla and vellus hair, and which goes on to form the terminal modulated hair. Now, if you look at the clinical presentation of women with PCOS, it affects the woman from starting from the time when she starts with periods, from the adolescence, then when she has to try for pregnancy in the reproductive age group, and then also it progresses on to the menopausal age group. So if you look at the women presenting to us in the clinic, the young girls, which are the adolescent age group, they mainly present with the menstrual irregularity. They might have either polymenorrhea or they might have oligomenorrhea. And their main concern, because they are young and growing, their main concerns are the cosmetic ones, which are there in the form of acne, hirsutism and hair loss. So we have to treat the patients accordingly at what age group they are presenting to us. Now, when a woman enters into the reproductive age group, the main concern and the main problem that she comes to us is with infertility. And because of the elevated LH levels and altered progesterone levels, there is more chances of early pregnancy loss. And even if once she gets pregnant, the chances of having pregnancy-induced hypertension and gestational diabetes mellitus are more than normal than the control population. Now, once she is done with the pregnancy and she enters the menopause, then comes the role of basically the physicians, because these ladies are very prone to metabolic syndrome, and because of the too much of the build-up of the endometrium and delayed periods, there are increased chances of CA endometrium, and obesity is common to all the three age groups. So these are the problems which the women face who have PCOS. Now, what are the management options that you have in PCOS? The objectives of the treatment are at the stage where woman is presenting to you. In adolescent age group, there is treatment of oligomenorrhea and amenorrhea. The management of hirsutism and acne is important for them. The management of insulin resistance and glucose intolerance, and the females who are married and who are wanting to get pregnant, we have to help them how to get pregnant. So first of all, obesity and PCOS, both of them are so correlated that lifestyle management, which includes diet and exercise and weight loss, is the most important thing which should be advised to all the females. In diet, basically, we should be prescribing the diet which is low in saturated fats and which has low glycemic index foods, which includes bran, cereals, mixed grains, breads, lentils and soya. If you look at the exercises, I think you people know better than us. The American Diabetes Association recommends 150 minutes of moderate to vigorous exercise for the individuals who present with impaired glucose tolerance, and it should be distributed over 3 days. And for long-term weight reduction, 1 hour per day of the exercise is recommended. It has been seen that even if a lady reduces weight by just 5%, there is significant restoration of the ovulation. And the mechanism of action of the weight loss is that it lowers the circulating free androgen and insulin levels and increases sex hormone binding globulins, thereby decreasing the total free testosterone. Then coming to the medical management, you have insulin sensitizers which improve hyperinsulinemia and they regulate the reproductive endocrine axis also. And in that you have biguanides and thiazolidinediones, and in biguanides metformin is the most commonly used anti-hyperglycemic drug. The dose is 500 milligrams to 1500 milligrams daily, but because of the GI side effects, we usually start with 500 milligram once a day for 1 week and slowly go on increasing it to twice a day and then 3 times a day. And now you have sustained release tablets also of 1000 milligrams, so you can give that once a day. Metformin in pregnancy is supposed to be a category B drug, and before or during the first trimester it doesn't compromise the health of the mother or fetus. And in my own practice, if a PCOS patient conceives on metformin, it is advisable to continue it for initial 3 months because it has been seen that it decreases the risk of early pregnancy loss. So it is better to continue for first 3 months, and there have been no reported incidences of congenital malformation when the patient is on metformin. Then you have other drugs, pioglitazone and triglitazone, which is not available in India. This is the new drug which is now replacing metformin, myoinositol, which is given in the dose of 2 milligrams per day. And it acts that because the insulin inositol levels in PCOS are reduced in the woman, which leads to the decreased P13 kinase activity and which leads to increased glucose intolerance and insulin resistance. And this was a study which was published in Gynecol Endocrinology, which showed that it was a randomized control study, and they showed that if the myoinositol was given for 2 grams per day, it actually benefited the PCO woman in all aspects. It decreases both the insulin and the BMI. The HOMA index is improved, which is a significant marker of insulin resistance. HOMA index more than 2.5 is considered to be a reasonable indicator of insulin resistance, and it was shown to reduce the total and free testosterone levels, hirsutism, acne, etc. Everything was improved. Coming to the management of oligo and amenorrhea, we have OC pills and cyclic provera or norethistérone. I will not go too much into the details, but the OC pills containing new progestins such as desogestrel, gestodin, drospirenone are preferable because of their lesser side effects, and a combination of ethinyl estradiol with cyproterone acetate, which comes by the name of Diane 35 or Crimson 35, which is popularly used, that is supposed to be very good. The progestins can also be given when you have to give the young lady long-term long-term oral contraceptive pills, because that's not acceptable and it has its own side effects. So you can put them, once the periods are regularized, you can put them on progesterone in the dose of 20 to 40 milligrams daily. Cyproterone acetate with ethinyl estradiol 35 milligrams per day is started from day 3 to day 5 of the cycles to maintain the regular cycles. Then coming to PCOS and infertility, I will not go too much into the detail because that is what we are dealing with. Because you have defect at every level in PCOS, you have poor oocyte quality, then there is endometrial abnormality, so it affects everything starting from ovulation, fertilization, implantation, fetal viability, and the recurrent miscarriages because of the hyperinsulinemia. I'll just summarize how you can manage the patient of infertility, which was actually a PCOS, ASHRAE ASRM PCOS consensus group in 2007, which gave the outlines for the management of PCOS. The first and foremost, as we said, was lifestyle modification, and at least 6 months should be given to a lady for reducing the weight. Then first line of treatment is the clomiphene citrate. If the patient doesn't ovulate on clomiphene citrate, you can add metformin to the patients who have glucose intolerance. If the patient doesn't respond to this, then you can go on to give gonadotropins, and at least 6 cycles of IUI are recommended. And if the patient doesn't conceive on 6 cycles of IUI, that patient should be referred for assisted reproductive technologies. The patients who do not respond to clomiphene citrate and gonadotropins and the LH levels remain persistently high, which could be more than 10 international units, those patients can be offered laparoscopic ovarian drilling, which can also help the patients too. So this is what I have summarized, so I am not going into the detail. We'll come to the management of the PCOS in metabolic syndrome. The use of metformin is actually not advisable to all the patients. Only those patients who have glucose intolerance should be offered this metformin tablets, and not to everybody. Again, when the patient is going for assisted reproductive technologies, because there is defect at every level, the conception rates are lower as compared to the normal population. In pregnancy, again, the pregnancy loss is higher in the patients of PCOS, and you can see that the risk of perinatal mortality, the preterm births, PIH, GDM, everything goes high in patients of PCOS. Coming to the metabolic syndrome, which is actually the most important thing in menopausal patients, it is basically the insulin resistance which leads to atherosclerosis, dyslipidemia, decreased fibrinolytic activity, hyperuricemia, obesity, and the other symptoms. And the risk of cardiovascular risk factors are also related to the insulin resistance. And criteria for the metabolic syndrome in PCOS are: if the patient has abdominal obesity, which is waist circumference more than 88 centimeters as given by the International Diabetic Federation, triglycerides more than 150, HDL cholesterol less than 50, BP if systolic is more than 130, diastolic more than 85, fasting blood sugar levels more than 110 milligrams. If any of 3 of these criteria are present out of the 5, that patient is actually falls into the category of metabolic syndrome. The suggested evaluation for the patients with PCOS is: whenever a lady comes to you, the physical examination, blood pressure should be monitored every time, and it is seen that most of the patients, about 30% of the patients, have elevated blood pressures. The BMI should be taken, waist circumference to determine the body fat distribution should be done. The presence of the stigmata of hyperandrogenism and insulin resistance should be looked for. And all the patients of PCOS should be offered 2-hour OGTT, and you know the values of OGTT, what is normal and what is abnormal. The American Diabetes Association recommends 2-hour OGTT. And hyperandrogenemia is defined as when the total testosterone levels are more than 0.8 nanogram per milliliter, or free testosterone levels are more than 0.006, or DHEAS levels are more than 350. That is the patient who has hyperandrogenemia. Then hyperinsulinemia, again, if the fasting serum insulin levels are greater than 20. And the most other methods which are used is the glucose to insulin ratio less than 4.5. It is consistent with the insulin resistance. As per the American College of Obstetricians and Gynecologists, who should be screened for diabetes mellitus? Women with a diagnosis of PCOS should be offered fasting blood sugar OGTT, because there is 2 to 5-fold increased risk of diabetes mellitus than the controls. Does it have a long-term cardiovascular effect, and who should be screened? BMI, fasting lipids, triglycerides, and metabolic risk factors are the patients who should be screened for all these things. And there's just 1, 2, 3 slides. In women with PCOS who is not attempting to conceive, what is the best medical maintenance therapy? Apart from the other things which we have summarized already, statins are the new things which are now getting emerging support, but the long-term benefits are still not well understood. I'll not be able to cover the treatment of hirsutism. There are a lot of things in this. In hirsutism, I think only one spironolactone and eflornithine is US FDA approved for facial hair in the form of local creams. Looking at the current strategies for PCOS, genetics of the PCOS reveals that there is a defect in meiosis and early embryonic development, and it is not only the females or the daughters who can be affected, but the brothers or the sons of the parents who are having PCOS are at a greater risk of developing insulin resistance or diabetes. So PCOS can be inherited by both daughter as well as sons. These are the few good websites on PCOS which can give you a lot of information. I thank you for your patient hearing.
Thank you.